Hello everyone, welcome back for this week's EKG. We have a very good one for you this week that I'm excited to talk about. It starts with a 72-year-old female who called for difficulty breathing. She's got a history of COPD, she's used her nebs and they're not really helping. She's still feeling short of breath and having a little bit of chest pain. So you set her up, you get a set of vitals, and here's what you find. She's tachycardic at 119, she's normotensive, 117/40, with an oxygen saturation of 76% on room air. Sugar's 186. You throw her on the capnography as you're getting her set up for some supplemental oxygen, and you see that her CO2 is 51 with a shark fin waveform, suggesting that this truly is a pretty severe COPD exacerbation. So as you're addressing her airway, which always comes first, we're treating her hypoxia, trying to get that better. We also are going to move to a 12 lead once her airway is adequately addressed, and here is what we see. I'll give you a second to take a look at that, and then we'll look at it very closely together. Just like always, we start with the rate first. The computer's telling me that the rate is 129, so I think I'll agree with that here. It looks fast, but it's very irregular. So if you look right here, like here's one that lines up with the QRS. We'll do 300, 150. This is actually, this interval here is greater than 150. But if we look at this interval here, 300, 150, again, right around 150, 300, 150, between 100 and 150. So she's definitely tachycardic, but it seems variable. And then we move to our rhythm, so we just decided that it's irregular, which I think everyone can agree with. But the next question is this sinus in origin. Do we see P waves before every QRS? And this is where this one is very interesting. Our best place to see P waves is in lead 2, sometimes lead V1. I'll start with 2 because it's closer to me. We have a P wave before this QRS. I see one here. Maybe a little tiny one there with a really short PR. Then here's another nice round one, a bigger, thinner one. So it does look like there's P waves before most every QRS, which when at first glance, I think this would be very tempting to call this AFib with RVR. But as you look closer at these P waves in the setting of a patient with bad COPD, every one of these P waves has a different morphology, which suggests that maybe they're coming from a different origin. So see how this one is nice and round, and then this PR is that distance, where this is super tiny and kind of pointy with a really tiny PR. Here's another one that's a little more peaked with a different PR. And as you look at each of these P waves, as we move down, they change shapes, which is something to take note of for later. This is going to be our diagnostic criteria on this one. But it is irregular. It does appear to be coming with a signal coming from above the AV node that's generating a QRS complex and a ventricular depolarization. Next, we move on to our axis. We look at leads 1 and AVF. In general, remember, lead 1 is your left thumb. We'll give that one a thumbs up. AVF is your right thumb. QRS is mostly up. We end up with 2 thumbs up, which will give us a normal axis here. Intervals we look at, very concerned about the QRS and the QTC. QRS, we want less than 120. This is a nice and narrow QRS. And then QTC, we want to be less than 450. Really, we get concerned over 500. This one actually is a little bit long. So we have a long QT here in the setting of this tachycardia that's irregular. And we move on to look at our ST segments. So 2-3 AVF are our inferior leads. I'm looking here for any ST elevations or T-wave inversions. A little hard to tell because the baseline is wandering, probably because she's short of breath and breathing pretty hard. Best I can tell though, inferior leads, I don't see anything that's sticking out for ischemia. 1 in AVL. Again, I tend to like to look for inverted T waves here, but it's difficult to tell. I'll just give her credit and say that this is okay. V1 through V6, again, looking for ST segment depressions, T-wave inversions. You may be able to argue this one kind of catches my eye here for ST segment depression, but then the next segment looks okay. So that may have just been a little bit of that wandering baseline there. in general, I'll call it no ST elevation. The big thing here is these different shapes of P waves. And what that makes me think of in the setting of a COPD patient is something called multifocal atrial tachycardia, also known as MAT for short. It's a lot easier to say. And the criteria for this is a heart rate that's over 100, so we definitely had a tachycardic rhythm. Very irregular, very unpredictable, with varying PP, PR, and R to R intervals, and we saw that on our 12 lead. And this is where you really dial into your P waves, because in order to meet criteria for multifocal atrial tachycardia, you need 3 different shapes and types of P waves. And you can see here on this example rhythm strip, there's a nice little round P wave here. This one's kind of pointing like a shark fin with a longer PR. And this one has kind of merged into the T wave here. And all throughout, you see different shapes of P waves and different intervals between the P wave and the QRS. And so those are the criteria you need for MAT. The reason this is important is because there is a 60% in-hospital mortality for these folks, and their chances of dying within the next year are very high. And so can you treat this? Actually, you can make it get better by treating the underlying disease. So what's happening in the heart when you catch MAT is that just like a supraventricular tachycardia, which is essentially what this is, beats are being conducted very fast through the AV node, so you have a narrow QRS, but the origin is coming from all over the atria, and this is usually due to stretch on the right side of the heart due to cor pulmonale or high pressures on the right side. It can also be induced by hypoxia, hypercarbia, and increased sympathetic drive, all of which we see in this patient. She was hypoxic, hypercarbic, meaning she had a high end-tidal CO2, and she's very anxious and amped up because of this, right? Her body's trying to oxygenate itself, so she's got a big epinephrine surge. And so if we can treat her hypoxia by giving her oxygen, possibly CPAP, DEX, duoneb, all of the things that we normally do for COPD exacerbations, we can increase her oxygenation, decrease her retention of CO2, make her body not have to work as hard, and decrease her sympathetic drive. And then we may be able to follow EKG changes in this patient as she gets better from her underlying cause. Okay, so this is very important to recognize, very important to understand, and to see it, it's easy to quickly think that you have AFib with RVR, but in the right setting, recognize that this has a high mortality in your COPD patients, and their disease is probably pretty bad. And so just one more look at our 12 lead here. We have a very irregular narrow complex tachycardia at a rate of 129 with different shapes of P waves and different PR intervals that suggest multifocal atrial tachycardia in the setting of a hypoxic hypercarbic patient. And that's all we have for you this week. Thanks for listening in, and we'll see you next week.